Hi, Ate Priscilla.
Hi, how are you? So
Good.
this is the big day. I just made you co-host.
Okay. Can I try to share my screen?
Yes. Yeah, you should be able as a co-host to do that. You know the slides, I didn't realize they are individual ones. So you're gonna advance it anyway, right?
Yeah,
Because I
I'll do it.
have
Yeah.
a problem looking for each one of them and advancing it if they're not together.
Right. Yeah, I had a system that I created. So are you able to see this? Is this okay?
Yes, I can see it.
Okay. And then the next one is so I'll tip that. And then that's the next one. It's big enough, right, for the screen?
Yes,
Okay.
it's very big. I mean,
Okay.
I have a monitor. I'm gonna shut this monitor off later because when I find like if I were to share one of the speakers' PowerPoint, if I have a monitor, it's kind of messes it up.
Okay. All right. Let me stop. Okay. There's two people. I don't know who these people are.
Yeah, they are attendees. Pearlie is the president of PNA San Diego.
I can message them. I can just say, we'll let you in at.
Yes, that can you send it? Do you need to send it individually or
I can send it to the waiting room participants.
Okay.
So I
Yeah.
can say,
Tell them you will be admitting people shortly before 8 o'clock.
okay.
Just say the
Hello?
planning committee is, making sure everything is working. Let me just grab a scarf.
I'll just say thank you for waiting.
It got so warm in New York. I have to put up the air conditioning. I didn't want to be sweating so much while trying. We had the heat on for a few days, but now I have the like all black. Maybe later. Yeah, they are early. Yeah, PNA San Diego has a program tomorrow. And of course, I'm one of the speakers tomorrow at San Diego, but I'm gonna hop in right after to go to our, remember PNAA has a program tomorrow at 2 o'clock. It's the DEI BSJ committee, diversity, equity, inclusion, belongingness, social justice. There's I know there's just too many.
Too many.
I know it's so hard to
So busy, yeah.
to all of them, and even if I wanted to, sometimes they conflict.
Yeah. Okay, send them a message. Thank you for waiting. We will let you in about 10 minutes prior to the start of the webinar.
Yeah.
The committee is just checking technical issues.
Okay, that's wonderful. Are you in a doctoral program?
No.
Not yet. Are we recording already or?
Yeah, I think you're recording already.
Yeah, I'm gonna pause it.
25 and 26 of 2024 at the Global Summit and International Nursing Conference in Iloilo City. Thank you, and we are again united as Filipinos all across the world, serving people throughout the world. Thank you.
Hi, my name is Marlon Saria, President-elect for the Philippine Nursing Association of America. And I am here with Dr. Robin Begley, the Chief Executive Officer for the American Organization for Nurse Leaders and the Chief Nursing Officer for the American Hospital Association.
Thank you so much. I am so excited to be presenting in Iloilo City at the conference January
25 and 26.
25 and 26. It's my pleasure. It has actually been one of my lifelong dreams to visit the Philippines, and I'm so excited to be visiting your country. I hope you can join me. We would love to have a large crowd, and we're going to have a good time.
Join us the 5th Global Summit and the 14th International Nursing Conference in Iloilo City. We'll see you there. Hi, my name is Marlon, President-elect of the Philippine Nurses Association of America, and we are at the Embassy of the Republic of the Philippines. I'm here with Julia Choi, CEO of the Asian Pacific. Help me with the acronym.
Sure. Hi, I'm Julia Choi, President and CEO of the Asian and Pacific Islander American Health Forum. I'm so honored to be here with you, Marlon, here at the Embassy of the Philippines here in Washington, D.C.
Great, thank you, Juliet. Juliet will be one of our keynote speakers at the Global Summit, the 5th Global Summit and the 14th International Nursing Conference in Iloilo City, January 2024.
I am so looking forward to your Global Summit in January, and I look forward to meeting so many more of the Filipino nurses from around the world. I hope to see you then, and take good care, good health to all of you, and see you in January.
Thank you, Juliet.
Thank you, Marlon.
See you all in January in Iloilo.
Hi, I'm Orly Remejo. I'm the Vice President of the Philippine Nurses Association of America. I'm so pleased to be with here this afternoon. Dr. Peter Picciozzi, the President of the CGFNS International. And Dr. Picciozzi will be one of our speakers at the 14th International Nursing Conference and Global Summit come January in Iloilo City.
Thank you so much. Really looking forward to meeting with all of you at the Philippine Nurses Association of America conference. Looking forward to exploring new opportunities and ideas that you have but listening to how we can improve our services to support nurses from the Philippines as they're coming over to the United States and other countries that we support, Canada and New Zealand. So really, very much looking forward to meeting with all of you.
Thank you, Dr. Prishosi. So, see you there, Iloilo City.
Good evening, everyone. Can you all hear me?
Yes.
Okay. All right. So I just want to run this program quickly. We're going to start with a prayer and then a welcome and then an introduction of the speakers. And then after that, the two speakers will talk and then we'll do a Q&A and then a raffle and then closing comments. And then the last one would be the post-test and evaluation. And we will have the link and the QR code posted on the screen for about 60 seconds or so. Okay. So I'll just gonna start formally. Good evening, everyone. Welcome and thank you for logging in or dialing in for our webinar tonight. My name is Misma Amados from PNA Metro DC and a member of the PNAA Ethics Committee for 2022 and 2024. And I will be your Master of Ceremonies for tonight's webinar entitled Ethics and Health Equity, Perspectives, Conversations, and Call to Action. If I can just request everybody to mute their microphones, unless of course, you are being, unless you are asking a question. So our objectives for tonight's webinar, at the completion of this webinar, participants will explore the role of ethics in advancing health equity, apply principles of social justice in nursing practice, education, policymaking, and research, apply virtue ethics in navigating ethical dilemmas in organizations, identify key moral principles of virtue ethics and how they are applicable to practices in healthcare, particularly elder care. We have two renowned speakers on this topic. You can expect each speaker to have the floor for about half an hour each, and we'll conduct an ample amount of time for Q&A at the end of these two speakers' talks. So if you have any questions during the webinar, please type them on our chat box. We will address them during the Q&A. So tonight's webinar awards 1.25 contact hours. In order to obtain full credit, one must attend the entire program, complete the post-test and evaluation. We'll post the QR code and the link at the end of the webinar for the attendees to complete, as well as the link will be posted at the chat box towards the end of the program. The Philippine Nurses Association of America Provider Unit is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation, P0613. The speakers have declared no relevant financial relationships with ineligible companies, and this presentation has no commercial support and is not a joint provider activity. So may I now call on Ate Trini Allaire, who is gonna provide us our prayer for tonight's event, followed by a welcome from our hardworking Ethics Committee Chair, Dr. Priscilla Segar.
Bow our head to feel the presence of our Almighty God. In the name of the Father, and of the Holy Spirit. Heavenly Father, as we gather this evening, we ask for your guidance and wisdom, Lord, and to thank you for allowing us tonight to continue our learning and share our knowledge and time with one another by attending tonight's Ethics Summit. We humbly ask that the Holy Spirit will shower our speakers, Dr. Dula Pacquiao and Dr. Charles Zola, your greatest inspiration, so that they may share their knowledge on the topics that they will discuss, and for us to be good listeners and participants. We pray and thank the committee organizers who work hard that the objectives that they have set may all be achieved. To this, O Lord, we pray. In the name of the Father, and Son, Holy Spirit. Amen.
Good evening, everyone. Welcome to the PNAA Ethics Summit. This is an evening of discourse about ethics, health equity, social justice, and virtue ethics. As the Ethics Committee and Planning Committee Chair, I am honored to share with you what each one of us had worked very hard for months. The Future of Nursing 2020-2030 calls upon nurses to lead health equity initiatives to achieve positive health outcomes for all. May we, from all work and professional settings, contribute to achieve health equity here in the United States and globally. There are 27.9 million nurses worldwide, according to the World Health Organization. In the United States, Filipino nurses are among the 4 million strong nurses, the largest group of healthcare professionals. With their strength in numbers and public trust for over 23 years, nurses indeed are at vantage point to lead health equity initiatives. We thank our speakers, truly experts in their field, for their generosity of time and spirit to enlighten us this evening. This program carries 1.25 continuing education after your completion of the evaluation. Thank you all for taking the time from your busy schedule to join us tonight.
Thank you, ladies. And before we introduce our speakers, I would be remiss if I didn't recognize the work of this committee. Here we are. This committee meets once a month, and we are all well represented by each region. And our timekeeper and chat box moderators. So our timekeeper is Aga Santromana. He's the president of PNA Central Florida, and our chat box monitors are Dr. Priscilla Segar and Chat Music. All right, so if I can call on Chat Music now to introduce our first speaker. Chat is the president of the Golden Triangle.
Thank you. It is an honor to introduce Dr. Dula Pacquiao, Professor Emerita at Rutgers, the State University of New Jersey. She is Executive Director of the Philippine Nurses Association of New Jersey Foundation and a renowned consultant in transcultural nursing research, education, and practice. Dr. Pacquiao has advanced certification in transcultural nursing and is recognized for her expertise in transcultural nursing, culturally competent care, ethics, and health equity. She has recently published 2 books, Social Pathways of Health Vulnerability and Global Applications of Guidelines for Culturally Competent Healthcare. Dr. Pacquiao has served in several leadership roles, including president of the Philippine Nurses Association of New Jersey and the Transcultural Nursing Society. She founded and is a fellow of the Transcultural Nursing Scholars, and she holds a fellowship at the New York Academy of Medicine. Dr. Pacquiao has received approximately 28 awards for research, leadership, and teaching, including the Leininger Award for Transcultural Nursing Leadership, the New Jersey State Nurses Association's Educator Award, the Lifetime Achievement Award from Rutgers University, the Philippine Nurses Association of New Jersey's Education Legacy Award, and Sotejo Medal of Honor from the University of the Philippines Nursing Alumni Association. Dr. Pacquiao has obtained her Bachelor's of Science in Nursing from the University of the Philippines, a master's degree from Teachers College, Columbia University, and doctorate in education from Rutgers University. Please join me in welcoming Dr. Dula Pacquiao.
Dr. Pacquiao, please unmute yourself, Dr. Pacquiao.
Okay,
Thank you.
thank you. I wanted to say thank you for that nice introduction. And let me just put up my slides. And I can skip my objectives. Just remember that I had the first 2 objectives that Dr. Segar read before. So let's look at why it is so important to understand ethics, and why is it important that we are at the forefront of ethical care. If you look around the world, there are so many drivers of population vulnerabilities. And population diversity, we know that diversity is the main basis for discrimination, unequal treatment, unfair treatment, or whatever. Social inequity, we now know that it is the root cause of poor health. Climate change is something I will mention now, and I will discuss the other 3 more into my presentation. Climate change repeats the whole process. Those people that are poor and living in low resource environments, could not afford to get to live in better places, are worse off with climate change. So we now have a brand new set of refugees, your climate refugees, and a new set of homeless people. And neoliberalism, I will expand further. America probably is the big example of neoliberalist policy. And it impacts our health, our delivery of health, as well as access to health. So let me start with social inequity. We're all familiar with social determinants of health. These are conditions in which people are born, grow, live, work, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. We know that about 80% of why people are in poor health are conditioned by the conditions in which they live or they've been exposed to. Now, social determinants include social and physical environments. Social would include how we are arranged in stack within society, some groups at the top, other groups at the bottom. So where we're at the social hierarchy shows a pattern of privileges or vulnerabilities. The lower you are in the social strata, the more likely you are to be in poor health. And the lower you are in the social strata, you are likely to be situated in physical environments that are not really supportive of good health. So when we speak of social, we include socioeconomic status, and that's usually inclusive of education, occupation, and income. That includes also discrimination, the types of social support, access to healthcare. Physical environments would include the neighborhood and built environment, environmental safety and quality. Generally, social determinants refer to non-medical factors. But because we don't have universal healthcare in the US, it is included as one of a social determinant of poor health. So how do we embody? How does social class get into our body? How does being inferior in society get into your body? Nancy Krieger, from the epidemiologist from Harvard, said that we embody, our bodies actually are a map of our ecologies. So our social place and physical place impact our health, and they stem from historical, structural, and infrastructural forces. By structural, we mean the arrangement of policies and laws and arrangement of power and privileges in society. And with that comes the infrastructural piece that would implement those strata of society. Now, from Sir Michael Marmot, the first commissioner of the social determinants from WHO, his seminal study on white hole found that social status syndrome, social status, your place in the social hierarchy is a better predictor, is a greater predictor of poor health or early death. A stronger projector compared to what we monitor in biology and health, such as hypertension, smoking, drinking, and maybe high cholesterol and hypertension. Our exposure, according to Krieger, affects susceptibility, resistance, and adaptation to the stressors. So the more stresses we have in our history, the poorer is our health in the long run. That's why we think of early childhood adversity as something to be prevented. Now, I always like to go over allostatic load or overload, sometimes known as toxic stress, because this is the way to understand that you cannot blame people for what they are and who they are. Allostatic load is the resulting wear and tear from too much stress or inefficient allostasis. In other words, unmitigated stress for a longer period of time will create a cascade of abnormal impact in your body so that you really do not benefit from the old adage that acute stress really prepares you to fight or flee. When stress is unmitigated for long, such as stress from discrimination, stress from poverty, you have the inability to turn off the stress response when they are not needed. In fact, what happens is even when you are asleep, those stress hormones are so high that you probably will have stroke and high blood pressure in your sleep. You have ineffective response to stress or not adapting to the same stressor over time. While you are overloaded with stress hormones, by the time a new stress comes, you collapse. And it produces changes in personal behaviors or lifestyle that aggravate allostatic load. as smoking, overeating, drinking, and poor quality sleep. In other words, when people are in stress, look at what happened in Maine recently, right? With gun violence. This is the reason why a lot more incarcerated people are likely to be smoking and on drugs. And when you are under stress, you have poor quality of sleep. So the pathology of allostatic load really affects multiple body systems. It creates irreversible changes in the hippocampus. It changes your ability to remember. I mean, traumatic experiences are imprinted in your hippocampus so that you could suffer from flashbacks or PTSD. Your prefrontal cortex, the highest level of cognition and decision-making control, is also affected. It alters or impairs your ability to think and make decisions. The amygdala has to do with the control of fears, violence, and aggression. When the amygdala is affected, you will have poor control of aggression, violence, and fears. Amygdala hyperactivity also results in cardiovascular dysfunction. So in bullet number 2, these are your acute stress response. Remember, you have glucocorticoid, catecholamines, the pro and anti-inflammatory cytokines, and multiple systems. When they are circulating in your body all throughout, you will have chronic elevation of the same mediators, producing cardiovascular diseases such as hypertension, heart attack, and stroke. Cardiovascular disease, as I mentioned before, can also result from stress-related amygdala hyperactivity. You will have sleep deprivation, producing increased evening cortisol, insulin and blood glucose, elevated BP, reduced paraautonomic sympathetic nervous system response, elevated pro-inflammatory cytokines, and increased gut hormone known as ghrelin that increases appetite. So all of this, you end up with obesity, diabetes, immunosuppression and cancer, PTSD, imprinting of adverse experiences in early life, and mental illness. It's not a good thing to have chronic stress. That's why social determinants should be avoided as much as possible or treated or managed early in life. It's no wonder then that the same groups of people, those in poverty, those that experience enslavement, colonization, all of this, they experience health disparities, meaning they have excess burden of disease and mortality. And you could go down all these pathologies and you will see the same pattern occurs. And they are more likely to be in the roles of uninsured or those that are inadequately insured. So now let me talk about neoliberalism. Neoliberalism really is a marriage between political and economic philosophy. It is the idea that anything can be sold and can be profited from. That the idea that I can determine my own destiny out of our ethos, the main American ethos of individualism, is so compatible with neoliberalism. I can do what I want with my money. I don't have to pay for other people's welfare. They need to take care of them. That's what individualism is. Take care of yourself, both your health and getting better when you're ill. So what do we have? Our healthcare is market-based, profit-driven. We lack universal health coverage. We are the only wealthy democracy in the world without universal health care. So what we have is different tiers of health coverage. In fact, within our Medicare, I'm on Medicare now. I mean, if it's underwritten by Aetna or underwritten by United, you may have very different services, although it's all under universal health care. And those of you in employer-sponsored insurance, it's pretty good while you're working. But once you're sick and disabled, that will stop. When you need it the most, it will not be there. And hopefully you will be eligible for another type of insurance. So it is tough to be poor in this country. When you are on Medicaid, you know darn well your healthcare is not of the same quality as those with employer-sponsored insurance. So we have multiple payers making a whole lot of money out of our healthcare dollars, about $600 billion. And they're not coming back to reduce our premium to increase the roles of people that do not have healthcare. So our contracts with vendors and providers negotiated by these multiple players are competitive, secretive. And this is why your electronic health record is not global, because they're competing among themselves, healthcare systems competing among themselves. They don't want to share their data with other healthcare systems because the secretive contracts are likely to be there. So look at the ethical violations undergirding lack of universal access to care. One is we violate non-maleficence, doing no harm. When you are sick, and also when you need preventive care, very often you hesitate to go anywhere because you don't have insurance to pay for it. Or you may go for preventive care, but what happens when you're really sick and you need acute care? So we don't benefit these people who are poorly insured, uninsured, or have low quality healthcare based on their insurance. Remember that the main criterion for how you are cared for when you go into the facility is based on your insurance coverage. It is almost a sin. And we start with inequitable access to healthcare. We violate human rights to access to healthcare and quality care. We violate ethic of care. Ethic of care looks at the idea of advocacy for those who need it, but also to advocate for people who are really less powerful and affected by unfair treatment in society. Autonomy. If you're sick, you are unable to get help. And if you are of low health literacy and you're unable to get sort of comparative health education, you limit my self-autonomy, my ability to realize my potential as a human being. But worst of all, it violates justice or equity. And all this nice proclamation about equity, inclusion, and diversity, they hardly touch the main issue. Look at the policy, the healthcare infrastructure of this country. Start from there and really work at those issues that are very difficult to deal with. So now we go into the idea of diversity. Diversity, by definition, differences including varied demographics, perspectives, approaches, and competencies. But these are the basis usually why we are arranged in differential sort of positions in society. Some have more historical origins, and others maybe just more recently. But society really, I think every society, not just the US, but in the US, race is a big social determinant of health. Inclusion is the essential process for accepting the differences among us based on the core values of respect, fairness, and sense of being valued or sense of belonging. But inclusion, we need to unpack what needs for inclusion to occur. And equity is the absence of unfair, avoidable, remediable differences among population groups that are defined socially, economically, demographically, or geographically. So equity has more of outcomes rather than equality of access or funding. Let me tell you why. When we have equal access to something, that equal access does not really work because some groups have more needs than others. So equity allows for those differences in needs. Equity is not achieved unless the approach is based on the need of the population. So what is needed for that inclusion to occur or to happen? Social justice is a big one. According to the theorist John Rawls of justice, is a fair and just relation between individuals and groups in society. People in a society must make choices in order to protect those who are in lesser position. A just society is where the most vulnerable are rendered less vulnerable. In terms of crisis, think of the vulnerable first, because those who are not vulnerable are likely to have the means to take care of themselves first. They have more resources in their disposal, but the vulnerable, they truly need your immediate attention. This is why the COVID pandemic, who did it hurt the most? Those that were literally in the vulnerable groups, because the resources present in the community, the hospitals located in the community generally have very poor resources to begin with. And social justice identity is the internalization of the values of social justice and acting. Remember, acting to foster social equity. It's not enough that we're bothered about injustice, but it takes really some action. When you internalize that social identity, a justice identity, you are prone to action, to act to foster social equity so that we can we can promote respect for people's rights and dignity. We can act to benefit and make a difference in people's lives, not just tell them how to change their lives. People who are vulnerable have very low self-agency. Social justice identity also has to do with equal concern with material and non-material aspects of justice. Material has to do with distribution of material resources, but there are other non-material aspects of social justice, such as our goodwill, our kindness, our respect, our listening, our sensitivity. But you know, we can only do so much of that non-material aspects. We need resources in the long run. To become sustainable in our approaches, we need resources. Another part is the idea that we need to have empathy and compassion. This is from Nussbaum. She said we could all use more of it. Well, I look at empathy as the cognitive, relational identification with the other. So I can think of how it might be to live poorly, although I'm not poor. But empathy alone, I don't think, will prompt you to action unless you have the compassion. Compassion is the feeling part, is the sympathy part. You need to have both compassion and empathy to compel you to act. When you feel the suffering of others and understand how their suffering is very different from you and others, you have to act in order to help them. But compassion to me could not be taught in the classroom. Compassion needs experience. This is why we need to listen to people and their stories. For medical students, I always say, bring their clinical to the home environment, to the actual community. When you walk into the home, I used to visit patients in the projects. I would visit early in the morning because I don't want to see the drug dealers in the parking lot. And I would go up, although I would like to say to the patient, please walk every day. It's good for your heart. I myself took really a lot of fear to get up that elevator and reach their apartment. I would think twice about making that advice. I would do a practical sort of advice. Okay, let's measure what is the distance of this corridor from here to your bedroom, and let's see how many times you need to go back and forth, or give him the number of minutes to do that. You become more empathetic and compassionate in your teaching. Health education could not be acted upon unless you have a compassionate understanding of what others' lives are. The ethic of care is something that we need to understand. It comes from feminist theory and critical theory. Ethic of care is based on, emphasizes rather, relational connectedness and caring for others. The need to respond in relationships. In other words, when we meet people, we need to at least seek the idea that we want to develop a positive relationship. So we are attentive, we listen, we respond, we are sensitive. Because losing that connection is not going to build any further relationship. So the morality lie in human relationships. This is the idea of global citizenship. We need to understand how we are related to others, how we are connected to others. Because really, even the fire in Canada affects us in the Northeast. It affects the air quality in the Northeast. Air pollution does not care whether you're rich or poor. We all breathe the same. So relationship is really important, understanding how we can probably build connections with others. So cultural competence, I always think of cultural competence as ethical care, because the guru of cultural competence, Leininger, has defined culturally congruent or competent care as meaningful, beneficial, and enabling care that ameliorates human conditions and lifeways. So that alone, to me, is a ethical aspect of cultural competence. It's not just how they define it as working effectively with diversity. It's really getting that result, beneficial and enabling. Otherwise, it's not culturally competent. So I have looked at the knowledge, the skills, and the attitudes that are needed, and I will go through some of them. But for knowledge, we need self-awareness, of course, who we are, how different we are from others, but we need to know vulnerable as well as powerful groups. Why are they always vulnerable and the more powerful seems to stay in power? The social policies, healthcare infrastructure, and policies, as well as ethical principles. Now, for behaviors, cross-cultural communication, which I spoke yesterday, if you were in that other workshop, that webinar that we did, I will talk about building social capital. It is something that all nurses now in population-based health must have. Advocacy, empowerment, you understand that, and mediation. These are the three areas that WHO and the UN have really emphasized in terms of helping populations. Now, in terms of effective, cultural humility, you know the definition, but understand that cultural humility is not universal. It could not take the place of cultural competence because it's only an affective domain. You need to have cultural humility when you speak to the vulnerable populations. But by golly, when you're trying to convince politicians on their behalf, you have to throw away cultural humility and go in and let them know that you know what you're talking about. You need to be more forceful in that case. So cultural humility is something that is needed, but it needs to be apply dynamically in terms of the audience. Other authors call that dispositional humility, which I like because it has to do with your own attitude, your disposition to be humble. Reflexivity is your ability to really correct yourself. Nobody should tell you you are being a racist. That comes from self-awareness and reflexivity. And respect, we can talk about respect forever, but respect comes with compassionate understanding. And of course, the others I mentioned before. So why do we need humility, dispositional humility? And these were the authors I took them from. Because when you collaborate, you don't just collaborate with your fellow professionals, you also collaborate with the people who need the most. So collaborating with your vulnerable communities, you require not only professional competency, but positive dispositional factors or dispositional humility. Why? Because it allows accurate self-assessment, openness to new ideas, appreciate contribution of others, and generosity. Allows and creates an environment of fairness and equality. Next is advocacy and empowerment. Advocacy is more professional directed very often, and it's less sustainable than empowerment. Now, if Paulo Freire, the Brazilian philosopher who originated the idea of empowerment, said that you are not really empowered unless others recognize that you are empowered. So it is better to do community empowerment rather than just an individual or yourself. It's a social action process, both a process and an outcome, in which individuals and groups act to gain mastery over their lives in the context of changing their social and political environment. So here's the social capital that I wanted to talk to you. When you talk to patients in your care, these may be individual patient or a family, that's your entry to their community within networks. This is bonding. Within networks, people of the same race, the same neighborhood, the same needs, and the same goals usually bond together because they see each other more often, and they are bonded by that social place wherein they are located. But to create empowerment, you need to connect one community with another. And the more communities you bring together by bridging, the more they have empowerment. They can share ideas about shared problems, shared approaches that worked, and also shared connections. So bridging is the next step. Linking is the most important for us to know because we are part of that linking capital. We are the outsiders to the community, but we bring in expertise. We bring in expertise about policy making. We bring in policies about studies, statistical data analysis. We bring in connections that these communities may not have, such as connections with politicians and other political leaders. So it is important that we develop this skill. Exposure of students and mentoring students in the community is extremely important. Attending town meetings and meeting politicians and other community leaders. So the 3 levels of where you give care must always be in your head. Think ecological. At the micro level, we do it all the time. When we take care of patients, we can get entry to their own community. Make that part of building connections. Remember, the ethic of care is relational. But because we work in organization, at the meso level, we can engage our organization in collaborating with outside community. If you are in the power structure of the organization, please ask questions. What do you do for the underinsured? What do you do for the poor people in the community? How much of our budget is designated to help these people? So being involved in your organization, being part of committees so that you're involved in policy making is very important. But also if you're part of the top echelon, don't just be happy because you're well paid. In a capitalistic structure, nurses, your DONs or vice presidents make a lot of money and they forget very often. Engage them in terms of caring for the poor and the vulnerable. And the society level, this is where we need to make connections with our professional organizations, with our politicians, with community groups, civic groups, religious groups, so that we can make a dent really in changing policies, transforming communities. We can't transform without creating or changing policies and environments in which they live. Okay, so I will only mention this quickly because I know my time is in research. Those of you who are teaching, a good thing is secondary data analysis because you're using large data sets such as NHANES, your CDC data. Those are very important when you're trying to prove health disparity across populations. Health and policies do systematic reviews. Systematic reviews, for example, of how the Family Leave Act or something like that, a policy, really impacts people. The community-based participation research, very important because you are immersed in the community and what you learn, you put right away in your protocols. Environmental factors, make environmental factor as a study variable. There's one study from UK that I always quote that they studied, for example, obesity and high cholesterol and diabetes among workers commuting from their jobs to their homes. And what they found is that the more they ate fast foods along their commute, the higher are those blood levels and the higher is the weight. But because they included the number of fast foods along the route of commuting, they now know that the higher is the number of fast food restaurants in the environment, the more those things will occur at the individual level. So instead of just teaching the patient to change their diet, you might look at policy changing, zoning, so that you limit the number of fast foods in the area. And popular epidemiology is engaging your community members in gathering data about their community. They can write down when they call the police, what time, how many hours or minutes did the police respond. They can do popular epidemiology, how many times their garbage was not collected. So involve them in studying their own situations. And I will end with this, that this is from Dasein. It comes from the philosophy of the existential philosopher, Heidegger. Care, he says, is the basic structure of the inseparable connectedness of human beings with the world. And we need to learn about structures that are past, present, and future in order to be involved in that sense of caring. We need to have an intrinsic propensity to act otherwise rather than self-wise. And caring underlies all sustaining activities that maintain and repair the world as a site of life lived well together. Remember that word, repair the world. The act of social repair is reaching out to those in the community for whom things have broken down in an effort to redistribute opportunities for leading a dignified life. So we should not just focus on Filipinos. We need to focus on communities that are mostly vulnerable. Thank you.
Thank you so much, Dr. Pacquiao, for such an enlightening presentation. Our chat box is so busy now. It is starting to blow up, but audience, please hold on to your questions and we will address them during the Q&A. May I now call on Vicky Barbano from PNA San Diego to introduce our second speaker.
Good evening, everyone. It's an honor to introduce Dr. Charles Zola, Director of Catholic and Dominican Institute at Mount St. Mary's, Newburgh, New York. He served in different roles since 2016, and currently he is an associate professor and chair of philosophy and religious studies. He serves as assistant to the president for mission integration at Mount St. Mary's College. He worked as executive director of the Institute of Northeastern Pennsylvania. His area of specialization and interest include ethics in elder care, applied and business ethics, medical and social ethics, Catholic social thoughts, Catholic intellectual tradition. Dr. Zola obtained his bachelor's in philosophy cum laude at the University of Scranton in Scranton, Pennsylvania. He also has a master's in philosophy with distinction, doctorate in philosophy with distinction at the Catholic University of Louvain in Belgium. Let us give a warm welcome of applause to Dr. Charles Zola.
Thank you very much for the introduction. And I'm just, if you could indulge me till I do my share screen here. So is everybody able to see the screen?
Yes.
Okay, thank you so very much. I'm very grateful for the invitation from the Philippine Nursing Association of America to be with you this evening and share my thoughts, and especially to my colleague at Mount St. Mary College, Dr. Priscilla Sagar, for this invitation. I've always enjoyed working with nurses because the work that nurses do, and also those engaged with social work with the elderly, provide that information that feeds me in my exploration and research in terms of elder care. I became interested in elder care through my own personal experience of caring for my elderly parents when I graduated from grad school. And I found in that experience that some of the traditional ways of dealing with ethics that we learn in an academic setting are somehow a little bit mitigated in that experience. So I'm grateful that I can share my experiences with all of you here tonight, and look forward to hearing your experiences as well. And so I'm going to begin, as I said, with some of the basic moral principles that we've also just heard from Dr. Pakwa, and how it's normally approached in terms of medical ethics or healthcare ethics. And I'm also going to then reframe the picture in terms of virtue ethics, which I think is little spoken about in popular literature concerning healthcare ethics. And I think it's of an incredible resource for all who work in healthcare and social work, especially with the elderly. And then I'm going to focus specifically on the virtue of prudence as a way to navigate some of the ethical and social justice concerns for healthcare professionals in the settings that serve elders. And so the two learning outcomes which had been mentioned at the very top of the whole program was applying virtue ethics, as well as identifying some key moral principles involved with virtue ethics and how they can apply to the topic presented for us this evening for consideration. So I'd like to begin with the idea of framing the picture in the traditional sense of when we speak of ethics or medical ethics, we often frame that in the context of rights and obligations. I think this is especially true in American healthcare, where we hear so much about the rights of patients, and then healthcare providers take their cue from that. And their ethical and professional obligation is to respect those rights and to find the ways of how to fulfill those rights. And so patients have rights, which we define as a claim upon others, and healthcare providers, which I abbreviate for this presentation as HCPS, have an obligation, or we say a moral duty, to respect these rights. And so These, I'm sure we all are very familiar with, is the principle of autonomy, the right of self-determination, which also includes provision of information, keeping privacy so that patients are able to make an informed decision about their health care and about their healthcare choices. The principle of non-maleficence, of doing no harm, principle of beneficence, the obligation to do good for others, and then also something that we are focusing on this evening of justice, which is broadly defined as to give to each their due. And it is really these four basic medical ethical principles by which healthcare providers as well as patients go about in seeking healthcare in an ethical and professional manner. So I'd like to just pause. As a philosopher, I hope you will indulge in the discipline of philosophy, the idea of reflection, contemplation, and just ask those here in attendance, have you ever encountered a situation wherein these four categories have failed to adequately address an ethical dilemma? And I can share with you, going back to as I began, that in the experience of caring for my elderly parents, which was really a 15-year experience for which I'm very grateful, I found that these academic categories of medical ethics sometimes did not fit the situation within which I found myself. And I can say one of the easiest one that I think most of us have experienced if we're dealing with an elderly patient is autonomy. And often in the assisted living care facility, the worker would come over and ask a resident, what would you like for lunch? And the resident will say, you know, given their choices, they want a ham sandwich. And the person would bring back the ham sandwich, and the pleasantly confused elderly resident would say, "Oh, I don't want a ham sandwich. I want something else." And so the principle there was to respect the wishes of the resident, but they keep changing their mind because of lack of attention or lack of memory. And so, how are we upholding autonomy in such a circumstance where the elderly person constantly changes their mind? The other one I think is justice. When I teach medical ethics, I think this is a very easy example for our nursing students, is justice as to give to each their due. But suppose you have two or more patients who require your time, and your obligation is to give the due time for each patient. How do you budget that? How do you budget time in those circumstances? And so I think these medical ethical principles are certainly very important and certainly key. I'm not discounting them, but I think sometimes they do have limitations in actual practice. And so I'm going to borrow this quote from James Gustafson, that we respond to a moral dilemma the way in which we formulate the dilemma. The picture we draw of its salient features, it's largely determinative of the choices we have. And so I sometimes think if we frame the picture of elder care, and also the question of equity in healthcare delivery, that we sometimes need to broaden the perspective beyond those four basic categories of medical ethics. And it's from the virtue ethics tradition that I'd like to focus, because I think it can provide another way to enlarge the picture, certainly not to discount those four principles, but to enlarge the picture and how we might approach some of the dilemmas, ethical dilemmas that we confront in healthcare. And so I'm going to start with, in order to do that, to start with the root meaning of our English words, ethics and morals. And those words are derived, our English word ethics is derived from this Greek word ethos, or ta ethika, which is translated roughly as character or customs. In the Latin language, the exact same meaning, character or customs, is the Latin word mores. And I think we still use those words ethos and mores in everyday English. And what I like about these two words to frame our picture is that they direct us in the original meaning of what ethics and morality meant in the Greco-Roman world. And it was the idea that ethics was ultimately about cultivating a good life or a life lived well, to live life well. And for the ancient Greeks, going back to Socrates and Plato, Aristotle, the whole question, or the ethical question, or the moral question of life was, what are the characteristics of a good life? What are the customary things that one would do, or what would be the things that one would cultivate in order to achieve a life lived well? And I think for our purposes, that we can say that living life well, or living the good life, would apply both for the patient, right? Because that's exactly when the patient is making an ethical choice. They are making a choice in order to achieve a certain quality of life. And the flip side of that is then the healthcare ethics, or the professional ethics, must find the ways to do that for the patient, or for the person for whom they're caring. And these words of cultivation, or the customary actions to cultivate a good life, expresses a sort of an ongoingness about it. It is not a single act, but rather a series of acts which will result in optimal conditions for human flourishing. And I think this is important. Oftentimes when we talk about rights and obligations, a one-time instance will say you have violated somebody's right. Or for instance, to be a little bit legalistic, if you break the law, all of a sudden, the inference is that somehow the individual is a bad person. And we certainly know that in cases of negligence, that sometimes accidents happen, right? It's not intentional. And I think this is what virtue ethics does for us, or at least ethics contextualized in this Greco-Roman tradition from where virtue ethics springs, emphasizes that it's not necessarily the one-time incident that matters, but rather it is what has become what we would say characteristic, right? Character. It is what characterizes that care. Because given our human nature, we all make mistakes. And sometimes, we do drop the ball, but that is certainly not our ultimate intention. Nor could we say that if once in a while we do something good necessarily gives us a good character, right? One swallow or one robin doesn't necessarily make it springtime. So what I like about the idea of virtue as it's contextualized from the Greek tradition is that the moral life, or the ethical life, is really a wide swath of time. It is not a momentary thing, but it is rather something that is customary or characteristic of the person's lived experience. And so I'd like to use this image of living well in terms of healthcare, because when we deal with healthcare, we are dealing with something that is organic. It is something alive. It is an ongoing process. And I think when we think of the image of agriculture, agricultural science, cultivating crops that are abundant, fruitful, free of disease, plentiful, right? We automatically understand that idea of cultivation. And that is the exact same idea of what we are talking about in terms of happiness, that happiness is not a one-time experience, but rather it is a series of actions that we engage in order to live well or to flourish. And in healthcare, I think that is exactly what our objective is as healthcare practitioners, is to cultivate those practices in the same way farmers cultivate practices to produce an abundant and plentiful harvest, are to produce a quality of life for our patients or for those for whom we care. And to do so requires a bit of reflection. It requires some study. It does not happen automatically. It does not happen automatically. It requires work. And so for the Greeks, the way that they had framed this objective of creating a quality of life was through virtue. And virtue was the means by which one would live life well. And it was a striving for excellence. The Greek word virtue is translated into English as an excellence. And for the Greeks, excellence was of two kinds. It was an excellence in either thinking or an excellence in doing, which I will elaborate upon in a few more slides. But virtue, unlike rights and duties type of morality or legalistic morality of just simply following the law or making sure you don't break the law, virtue strives for something deeper. It speaks to the character of the person or of the moral agent. So unlike simply following the law, which is sort of a sense of, I would say, obedience and punishment, one of the lowest levels of an ethical code of we do something just so that we're not punished, right? When we talk about the stages of moral development. For virtue ethics, virtue really is an indication of the moral character of the person who's engaging in virtue, because virtue has to be genuine. It has to be reflective of the character and that the person really wants to do well for others. In that desire to do good for others, it renders the actions, right? So what that moral agent actually does is also something good. And this is accomplished how? But through the cultivation of habits. So we come back to that idea of habits or practices. And so the goal of virtue ethics is not only seeking the moral character of the person who is performing the action, but also that it has a consequence or it results in a life that is lived well. I extrapolate the idea of virtue then to healthcare ethics in this way, that healthcare ethics, from a virtue ethics perspective, is the cultivation of those best practices that enhance the quality of life for one's patients. That term best practices is very often used in a number of professional settings. In business, we speak about the best practices in business, the best practices in advertising, and I can go on. And when we speak about those best practices, really, what we are really talking about there are those customary things, right? To go back to that original idea of character and custom and ethos or mores. What are the things that one must do in order to cultivate a quality of life for one's patients? And so what I would propose for us to consider this evening is that healthcare workers achieve that not only through those four principles of autonomy, beneficence, non-maleficence, and justice, but also through the membership of professional organizations, such as tonight here with the PNAA. Because by their very nature, these professional organizations are striving to inculcate excellence or virtue within the profession. And how do we do that? Well, we do that through the collaboration with our colleagues in those professional organizations. And we can address those emerging challenges that we find ourselves in. Again, when COVID struck, we all knew what that was like. Everybody scrambled to find out what is the best way that we can deal with, what are the best practices to deal with this pandemic. We dialogue on research and how to address these both at the communal and the local level, practices that are implemented and evaluated for effectiveness. So through professional organizations, there's an evaluation, there's an assessment of these practices to see if their effectiveness. And based upon this dialogue, this discussion, this research, then the best practices are then adopted. And we recognize that professional organizations will sometimes, have policy changes because we find out what might have been a best practice, several years ago is no longer a best practice. So I think professional organizations are practicing virtue. They are striving for excellence in these collaborations and in the cultivation of dialogue among the professionals who are engaging in these questions. So going back to a deeper dive into virtue, say perhaps more academically, Aristotle had defined two types of virtue. There was intellectual virtue, which requires study and time. And these virtues are the excellences of thinking. So any academic discipline, biology, anatomy, physiology, the cultivation of excellence, right, of understanding of these particular disciplines. Then there was also the moral virtues. And moral virtues were the result of habit or custom. And so we come back to that idea of practice. The idea of practice makes perfect. And I think perhaps most of us would say patience is a virtue, and patience is something one has to practice to get good at. Some other common virtues are gratitude, generosity, etc. And so the virtues of prudence, though, is something that stands in between it. And that's why prudence is a unique virtue between the intellectual virtue of thinking and acting, insofar as the virtue of prudence has to understand. So there's this theoretical aspect of it, that one has to understand the goal of one's moral action, but must deliberate about the means to the end. And so prudence is always about not only understanding, but also thinking about how does one accomplish that end, and then has to see that that end is actually brought to fruition, right? So it's not simply enough to have a good intention and to know how to do something, but one actually has to see that it is carried out and executed. Now, in terms of prudence, in terms of this virtue of prudence, we're kind of left in maybe a vacuum here, is what exactly are the steps by which one can understand, deliberate, and execute. And the great philosopher, theologian, St. Thomas Aquinas elaborates on the virtue of prudence. And he says that prudence involves memory, it involves docility, which is the ability to learn, shrewdness, the ability to size up a situation, circumspection, to see extenuating circumstances, right, to see beyond the particulars of one case and to kind of take a broader viewpoint of it. Caution, so when executing something, to be aware of dangers that might be out there. And then foresight, to guesstimate, we might say, what would be the ultimate consequences of one's moral action. And so all of these are key components of the virtue of prudence. And I will quickly go over some of the ways that I think right now, perhaps everybody in this room has exercised prudence, but without probably knowing that. Memory and docility, examining the patient's past history, becoming familiar with their cultural, religious, ethnic traditions, the opportunity of CEUs, right, to keep abreast of their particular profession. These would all be examples of the integral parts of memory and docility. Shrewdness and circumspection, right, taking account of the location of the contact with the person, the environment. Perhaps there might be complications that the patient is dealing with. And so again, this would all be part of that virtue of prudence. And then caution and foresight. What might be potential negative interactions? What is the ultimate aim of the healthcare plan? And so all of these parts of the virtue of prudence are something that I think everyone is familiar with, but perhaps not in this context. And so I'd like to then extrapolate from this virtue ethics perspective and the virtue of prudence of how it might address elder care. One of the challenges of elder care, and there are many, is that elderly patients usually have decreased cognitive and physical abilities. And as those decrease, the amount of attention to be directed to them increases not only for the healthcare provider, but also for their caregivers. And our society, unfortunately, favors quick answers and values that are linked to youth and vitality. And so when we talk about equity in healthcare, I find that the elderly are really marginalized in American society, not only by society itself, but also by the elders themselves, who sometimes see themselves, they internalize those values and see themselves as unworthy of care. And we know the depression is one of the leading problems with the elderly in society. And so they internalize this sense of not fitting in with the predominant cultural values of American society. In particular, questions of driving that caregivers experience because of that decreased cognitive ability is when you have to take the keys away from the elderly person. I think more situated in the clinical setting is elder abuse, the many forms of elder abuse, physical, psychological, financial, sexual, neglect, abandonment. These are something that definitely healthcare providers are certainly aware of because of the interactions they have with elderly patients. And then, of course, end-of-life decisions, which of course do not necessarily have to happen in elder life, but it really is one of the main concerns given that age demographic. Depression, which I've already mentioned, substance abuse, which is one way that elders cope with depression, and then also sexuality, right? The question of sexual relations with a married couple, one partner might be pleasantly confused, and then the questions of consent, which is now emerging as an area of interest in terms of elder care. So I will suggest for our purposes that in order to address the sort of marginalization of the elderly and how as healthcare providers we can go about caring for them and providing that quality care that virtue ethics strives for, is that we frame this question within these three key moral values: inclusivity, respecting the intrinsic value and dignity of the person, and moral equality and protection. And so what do we mean by inclusivity? Inclusivity, I would frame it as embraces the totality of the life experience. Oftentimes we hear the elderly person saying, well, I'm past my prime, I'm over the hill, I'm too old for that, right? And I think in some sense, American society often looks at the elderly that way. And again, it takes us to that idea of marginalization. I love this quote from St. John Paul II. He wrote a letter to the elderly when he himself was elderly. And he has this quote that man remains forever made in the image of God, and each stage of life has its own beauty and its own task. And I think even if you disregard the religious point of the image of God, but the insight that each stage of human life has its beauty and its task. And so I think that we need to confront that idea that there's a prime of life. I think we need to maybe strive for a more equitable look at the life cycle, that each stage of life has its own particular beauty and its own particular value given the context of its chronological age. The intrinsic value of life, right? So if we could embrace that sort of view about the totality of the life experience, then we find that elder life has an intrinsic value. We are not human beings, that we are not judged by the things that we do, but that we are human beings and not human doings. And I think that part of the value that is attached to the stages of life is if you're in your prime, if you're productive, that is more valuable than somebody who may be elderly and unable to do the things that they might have done earlier in their life. And so that emphasis on the dignity of a human being rather than on the things that they can do. And third of all, moral equality and protection. So that, yes, people are different based upon their abilities, but that, that we are all morally equal given our human dignity. And that those who are most vulnerable in society, those who are marginalized, are deserving of protection because of that intrinsic value, that people are different, but all people are morally equal, even if they are not able to do all the things that they might have done. And so to return then to how can virtue of prudence help healthcare providers and those who work in elder care facilities, I will again review these 6 principal parts of the virtue of prudence. And I will then close with how I have seen that virtue of prudence applicable to this demographic. And I think that the virtue of prudence can decrease that marginalization, work for equity with elderly patients by cultivating positive values concerning the elderly that foster inclusivity. And in that idea of best practices, discern the ways by which we cultivate quality elder care through those principles of docility, memory, circumspection, etc., that I had just pointed out. Also being an advocate for redirecting those resources, especially with that foresight, like what is it that we want to see the outcome ultimately be? That's that important part of foresight, looking down the road. And then also prevent elder abuse, right? By exercising caution, right? Being aware of and circumspect about those possibilities where the elderly can be abused in a number of ways. So in summation then, I would say that virtue ethics strives to cultivate moral excellence with the goal of achieving a good life or a life lived well. And that virtue ethics seeks to cultivate those best practices to do so for both the patient as well as for the healthcare provider. So virtue, again, is a two-way street, not only for those for whom one cares, but also reflects the moral character of the individual. And then last of all, that prudence is not only the understanding of quality care, but discerning the means to that end, and then seeing that it is accomplished. So I thank you for your time, and I'm looking forward to having a discussion among our participants this evening.
Thank you so much, Dr. Zola, for such deeply impactful information. So we're not going to waste time. I'm going to call on Susan Gador from PNA New York to moderate our Q&A. Susan?
Please unmute yourself, Ms. Gador.
I'm sorry. Thank you, Ms. Pa. Good evening. Thank you, Dr. Pacquiao and Dr. Zola, again, on behalf of the Ethics Committee, and for your enlightening and inspiring and thought-provoking presentation. So without further ado, this is our Q&A section of the program. So there are a few questions. I hope I was able to capture them. Firstly, from Chris Escarilla, to Dr. Dula, you mentioned inequity amongst healthcare coverage. I hear stories from both sides of the spectrum. There is a difference between a private insurance versus a state-funded healthcare like Medicaid or Medi-Cal. In a private insurance, the co-pays and have to pay bigger amount in order to get procedures done, whereas those with a medical or Medicaid healthcare does not pay and co-pay, and their medications are free. For private insurance, there is still cost for prescriptions, including OTC medications. State-funded insurance are free, including over-the-counter medications. I don't see a question. This might just be a statement from Chris Escarilla. So the next question, then I'll move on.
Can I just make a comment
Okay,
on
so
that?
Dr.
Yeah.
Pacquiao, please.
That is the main problem. And I would not agree with the last statement, because we did a study of Medicaid recipients in urban Newark, one county, the same county. Both, if patients had Medicaid underwritten by Horizon, CVS will not accept it. Walgreens will not accept it. If it's underwritten by by United, I may have reversed the order, but anyway, what I'm trying to say to you that even among Medicaid, they can't even get their steroids for asthmatic children from the pharmacy, because the pharmacy does not accept certain contracts of the same program from Medicaid. So how, if that is mind-boggling for you, I mean, they don't get it free. In fact, one family on Medicaid, because this is a school child with asthma, you have to get a rescue inhaler that the child would need at home, and you need a rescue inhaler that is unused, brand new, for the school nurse to use in school. Medicaid will only pay for one. So the nurse or the doctor would prescribe a nebulizing drug that is delivered by a nebulizer. The drug is covered by Medicaid, but the nebulizer is not. So, I mean, to be on Medicaid, you really have to be poor. I mean, understand that if you look at the income of people to qualify for Medicaid, you really have to be poor to be on Medicaid. And expenses such as steroids, very expensive for these families, in fact, to buy. I mean, most of the time they only do rescue inhalers because that's all that the insurance will pay for.
Angelica.
Hi, this is Chris. I'm the one who placed that comment. I may have misspoke because I don't have much knowledge about Medicaid. However, I had some first-hand knowledge of the Medi-Cal since I am from California. Because oftentimes I am from an HMO entity, and most oftentimes I have patients coming to complain to me about how much they are paying their copay and stuff like that. And I also know firsthand that we do have patients covered by Medi-Cal, that everything was given to them free, including over-the-counter medications, as long as they are prescribed by the physician. And so it's just a matter of discussion, I guess. That's why I was bringing this up, because I do know the poverty level of those who qualifies for Medi-Cal. But I apologize. I must have misspoke, including Medicaid. I have not much knowledge about Medicaid in the East Coast. Thank you, Dr. Dula, for that enlightening information.
Thank you both. Now I'll give a question to Dr. Zola. Do you have any input with the effect of the pandemic with the nurses in the long-term care? Possibly you may have partially discussed this, but I wasn't certain if you specified the presentation or that topic specific to long-term care.
No, in terms of nursing and long-term care post-pandemic.
Yes.
And the question is about what?
Do you have any input with the effect of the pandemic with the nurses in long-term care?
No, I wouldn't be able to speak to that. It's not something that I've studied. Unless you're speaking about how would the virtue of prudence perhaps address that circumstance.
All right, thank you. Well, Dr. Pacquiao, how do we incorporate the social determinants of health in our own practice settings?
The hospital, if you are working in the hospital, that is the least location for acting on social determinants. That is why the focus of the talk is really to focus more on community and populations, because that's where you deal with social determinants. When people are very sick, you have to address the disease, right? But social determinants occur prior to even the disease or the illness occurs. So it's even before the preventive aspect. So I say that it's time that nurses and probably educators in the audience, that we focus and bridge more the idea of community health, public health, and really expose our students to that rather than expose them just to a hospital, because you decontextualize patients. You remove their background. You don't know where they're coming from when you see them in the hospital. It is actually dehumanizing. The postmodern philosopher Michel Foucault said that the worst thing that happened to medicine is when they created the hospital, and it became their own territory, their own laboratory, and every patient sort of are seen the same way for the disease and not much about other things. So I would say your involvement in BNAA is very good. Involvement in outside organizations, your church, your community. We have to do that individually and as a group.
Thank you, Dr. Sola. I think this is for Dr. Dr. Pacquiao. I think this question now is for Dr. Zola. It appears in your presentation that we can talk about virtue without talking about divine elements or the afterlife. Is this a correct assumption?
Yes, definitely. So it's amazing that virtue ethics, this idea of striving for a happy life, was something that was, the predominant ethical theory for the Greeks and the Romans. And in this sense, Saint Augustine and Saint Thomas Aquinas preserved that. They said there was a wealth of a good moral guidance in that virtue ethics tradition. And so what Saint Augustine and Saint Thomas did was said that besides those, the cardinal virtues that we inherited from the Greeks, they enlarged upon that and included the theological virtues of faith, hope, and charity, which are also virtues, but they're supernatural virtues, because those virtues, faith, hope, and charity, lead to happiness in the afterlife, whereas the other virtues strive for happiness in this life. And so, at least in the Christian religion, they preserve the idea of virtue ethics. And so virtue ethics is applicable to anyone, even if somebody was not even a believer in God or the gods, or a religious person. A virtue would still be a good approach, I think, to try to find happiness in life. And the Christian religion recognized that and expanded upon it. In fact, St. Thomas Aquinas speaks perhaps more about virtue than he does about the Ten Commandments. And so I think it can be, it's ethical theory that I think is very inclusive, because I think everyone can find something good in it.
Thank you, Dr. Zola. Going back to Dr. Pacquiao. Are you supporting Medicare for all then? So everyone gets coverage, as a lot of people work because of insurance. Thank you for an enlightening and interesting topic. That's from Luisa Valero.
I do support universal insurance. There should be at least an equal footing at the base. In countries that have universalistic system, they do have options for private. So if you don't want to wait long, maybe you can do that, but you pay for that. I think it's more equitable when we give some sort of equal access to everyone with the same sort of provisions. And the beauty of universal healthcare is that there's only one payer who can then negotiate prices. This is the reason why we're paying so much for drugs made in the US than Canadians pay for the same drugs. There is one negotiator for all vendors, all pharmacists, and all healthcare professionals. I know that some doctors may not like this, and some of you may not like it. But on the other hand, it's paid for by everyone's taxes. So you don't have to worry about your increasing premium compared to the others and how is your selection better than others. It's the same sort of base. That's equal. And what is not provided, if you have the means, go ahead and pay for it.
Thank you so much for that very engaging Q&A period. We are running out of time, and so what we'll do is, if we may field the questions to you both, Dr. Pacquiao and Dr. Dula, we will do that, gather them from the chat box. Thank you.
Yeah.
Okay, so that ends our Q&A. We are now ready for our raffle. May I call on Carol to do our raffle while she is preparing the tambiolo. I guess I can announce the prices. So we will have 4 $25 Amazon gift cards, which was donated by our committee co-chair, Kathy Abramiago, and a special book donated by Dr. Priscilla Segar. It's a book on transcultural nursing education strategies. So if you win this book, please give us your address so we can mail to you. Carol?
Okay, thank you, Ms. Pa. So let's go ahead and draw our first winner of $25 Amazon gift card. Elena Laboga. Congratulations, Elena. You have to be present to win. Can we hear from Elena? Elena, you can unmute and just say something. Okay, going once.
She's there. I saw her. She just
Put something on the chat box.
Okay.
She's
All
there.
right. Okay, that's me. All right, I see her now. Okay, Elena, thank you. Okay, drawing the next one. Charina Tino.
present. That's me.
Thank you, Charina. Congratulations. Next one.
Thank you.
Risa Mauricio. Congratulations, Risa.
Oh, wow.
Thank you. Carol, thank you, Priscilla and Ethics Committee. I would like to donate that to the Metro Houston chapter. So if you can just send that, please, to the Metro Houston chapter president.
The gift
Thank
card.
you.
Okay. All right. Thank
Actually, we need the addresses of all winners because Dr. Yago will be mailing those gift certificates, and I will also mail my book. Thank you.
Okay, thank you. Next one. This would be the fourth Amazon gift card. Let's see. Ida Laboga, Charina Tino, Risa Mauricio. Fourth one. I wanted to make sure it's correct because I might have to be abono here, you know. So okay.
Abono, is that a song, Carol?
Okay, Jocelyn Palua. Jocelyn Paluay.
I'm here.
Oh, Jocelyn, congratulations.
Thank you.
Welcome. Thank you, Dr. Yago, for your donations of Amazon gift cards. Last raffle is for the Trans-Cultural Nursing Education Strategies by Dr. Priscilla Sagar. And here we go. Victoria Cabradilla. Victoriana Cabradilla. Victoriana, can you unmute and say something?
Here.
I saw her name earlier. Victoriana, going once, twice.
I see her name.
Perhaps she left.
Okay, have to be present.
Okay. All right, we're gonna raffle again. Okay, I'm just scrolling through to see if her name is in here. Okay, all right, okay. Victoriana, I see you still log in. Can you unmute and say something?
It's unmuted, actually.
Okay.
No response.
All right, okay, we're gonna draw it. Okay, here's the next one. Teresa Gonsalvo. Teresa?
I have Teresa's address, but did we get the address for Dr. Yago for all the four winners?
Hello, Teresa, are you in? Okay.
Lisa is on a phone.
No, she was on a regular Zoom before. I saw her. There were only 3
Okay,
phones.
there you go. Teresa, unmute. You're muted. She's waving. Oh. Do you see-
Hello, can
Oh,
you hear
there
me
we go.
now?
Yes.
Hi.
Okay, sorry, I had technical issues and I'm on my phone and I'm in Chicago. So thank you so much. I would like to donate the book to PNA Indiana if they are interested, since I'm now in Indiana. Otherwise, I'd be happy to read the book, and thank you, Dr. Sager. So proud to be part of this group.
So should I mail it to you or to, I'll mail it to you and then you could donate it to
Sure, I'll donate it to Matty Upano, our president. Thank you.
Okay, thank you, Carol, and congratulations to all our winners. May I now call on Kathy Abraham Yago to close our webinar.
I would like to thank our speakers for their informative and relevant presentation this evening. At this time, I would like to summarize a few key points. In Dr. Pacquiao's presentation, I highlight a few points which were: number one, ethical violations undergird the lack of universal access to health care. Number two, social determinants of health are conditions which people are born, grow, live, work, and age that affect a wide range of health functioning and quality of life. This also includes social and physical environments. Number three, health advocacy encompasses direct service to the individual and family, as well as activities that promote health and access to healthcare in communities. Number four, community empowerment is a process and outcome in which individuals and group gain mastery over their lives and in the context of changing their social and political environment. And the last one, culture competence care is meaningful, beneficial, and enabling care. In Dr. Zola's lecture, I will also like to highlight a few points. Number one, virtue is normally defined as excellence in thinking and doing. Number two, healthcare ethics is the cultivation of those best practices that enhance the quality of life for one's patient. Number three, there are two types of virtues: intellectual virtue, which requires study and time, and the other is moral virtue, which is a result of habit and custom. Number five, moral values that should guide the elder care are inclusivity, dignity, moral equality and protection. And the last one, virtue ethics strives to cultivate moral excellence that results in a good life and a life well lived. Thank you. And to all our participants, thank you for taking the time and being with us today and hearing our amazing speakers today. Thank you.
Thank you,
Thank
Kathy.
you for the summary. Thank you very much.
And
good night,
for the
everyone.
information of everybody, there is a post-test and an evaluation if you want to claim your 1.25 contact hours. And we'll leave this for 30 seconds. There are 4 questions to answer in the test. Each is weighted 25 points, total of 100. And you have to score 75 in order to receive the contact hours. You're also required to complete the evaluation following the post-test. Your certificate of completion will be emailed to you by one of our team members. Well, that's all we've got for you here tonight. We appreciate you signing in this Friday night when you could be out there doing happy hour in this beautiful evening. And we hope that you have achieved our goals on behalf of the 2022-2024 PNAA Ethics Committee. Good night and have a great weekend.
Good night.
Good night.
Good night, everyone.
I did already.